Ready, sir.
Hello friends, I am Dr. Chaitanya Shembekar and today I am going to discuss with you medical management of endometriosis, what's new. So I bring greetings from Omega Hospital Nagpur along with Nagpur OBGYN Society, the Infertility Committee of AMOGS and Maharashtra chapter of ISAR, that is MSR. My special thanks to Dr. Sarita Agrawal and Dr. Neeraj Bagde for giving me this opportunity. I would love to visit AIIMS Raipur physically whenever I get chance, but this time we are meeting virtually. Uh, Come 2022, and there came new guidelines for ESHREAM, and we have been waiting since long for these guidelines because the last guidelines were in the year 2014. So I must say that हुजूर आते आते बहुत देर कर दी. Actually, if you just look at the new guidelines, it is nothing but the old wine in new bottle, and you can say that endometriosis is revisited. The definition of endometriosis, as we all know, is very classical. It is defined as a disease characterized by the presence of endometrium like epithelium and or stroma outside the endometrium and myometrium, usually with an associated inflammatory process. This inflammatory process is something which is important, and we all should remember that inflammatory process plays an important role as far as endometriosis is concerned. There are two impacts of endometriosis. One is pain and second is infertility, and the incidence is very high. It is 2 to 10% in general population, and up to 50% of infertile women may have some element of endometriosis associated with infertility. So the incidence is very high. Now I'll discuss a case of Neha, because from this case we are going to discuss about the strategy as far as the medical management is concerned in case of endometriosis. Now Neha actually is a case of endometriosis. She is a young professional, 25-year-old, tall and beautiful, not yet married. She is having severe dysmenorrhea and she has pain which actually is there after menses and which continues even after menses. Nobody is aware that she has endometriosis. She is very popular in her college, she is best in her profession, but she is postponing marriage because of this pain. Now, the problem with this pain is that this pain is not accepted by society unless it is in connection with physical injury. Suppose आपको फ्रैक्चर हुआ, फ्रैक्चर आर्म हुआ, तो लोगों की सिंपैथी आपके साथ रहती है. लोग पूछते हैं अरे कैसे हुआ, कहाँ गिर गया. देन दे विल आस्क यू प्लास्टर कब निकलने वाला है. वंस योर प्लास्टर इज आउट, देन दे विल आस्क यू फिजियोथेरेपी कब चालू होने वाली है. So there is some physical connection, and then once everything is over, there is a sigh of relief. So there is some physical connection with the pain, and therefore the people discuss about this pain. But as far as endometriosis is concerned, the problem of endometriosis is that nobody is able to understand the problem associated with pain in endometriosis, and women cannot discuss it over coffee with anybody. So this has got a bearing on society in general through direct and indirect cost, as well as problem with the pain and infertility. There are various options as far as pain relief is concerned. You may improve the pain by hormonal suppression, by pro-apoptotic or anti-inflammatory actions, or by surgical removal of or destruction of the tissue. So there are many options which are available. We will be discussing all the options one by one, but this is a list, though this is a very busy slide and very exhaustive list of various options available. I'll just quickly go through all the options which are available with us. The first which comes is the hormonal treatment, which is actually considered as a first line treatment in the management of endometriosis. And the first thing here comes is the combined OC pills, which is actually a first line therapy which suppresses the ovarian hormones. It is the advantage of this treatment is it is cost effective, and but there are problems like long term problems like patient may have thromboembolism. Then the second comes the progesterone containing hormones or contraceptives. And this progesterone is also good because there, if you are not, there is a contraindication for estrogen, you can definitely try these hormones. They are available in oral forms in the form of dydrogesterone, gestrinone, linesterol, medroxyprogesterone acetate, ciproterone acetate. They are available in the form of injections like uh, Magestrol, or there are the LNG IOS, which is available, which is in the form of intrauterine device, and then there are various modes of delivery of the drug which is available. The other drug which is available is selective progesterone receptor modulator. and this includes mifepristone, nulipristal, and the drugs which are used for the treatment of adenomyosis, endometriosis, as well as fibroids. The gonadotropin releasing hormones or GnRH agonist is one more class of drug which is very good in its action but may have its effect in the form of the osteoporosis or menopausal symptoms. Similarly, GnRH antagonists are also good, and cetrorelix is one drug which can be tried, though still it is in the experimental stage. NSAIDs is something which you can definitely try for the pain relief. Aromatase inhibitors are available, which can be given orally, and they are third generation aromatase inhibitors like letrozole, which can be given in the treatment of endometriosis. Danazol is one drug which was popular once upon a time, but because of its side effects, the use has decreased. Then newer therapies of endometriosis like anti-angiogenesis factors, like dopamine receptor agonists like cabergoline. Statins can also be considered as a good treatment. TNF alpha blockers are available, and pentoxifylline is also available. But all these newer therapies, they are still under experimental stage, and you cannot say that these drugs can be used for pain unless it is experimentally proved by human studies. So we have dysmenorrhea, dysphagia, dysuria, dyschezia, and non-menstrual pain. So many types of pains which are there associated with endometriosis. And if you just look at the diagnosis of endometriosis, the new guidelines they say that the individual can actually present with clinical symptoms where you can predict the presence of endometriosis, which includes dysmenorrhea, deep dyspareunia, dysuria, dyschezia, painful rectal bleeding, hematuria, shoulder tip pain, or even catamenial pneumothorax, which we have learned during our MBBS days, cyclical cough, hemoptysis, chest pain, scar swelling, or pain in the scar because of the scar endometriosis, fatigability, and even infertility. So all these things can be associated with endometriosis. Uh, on 8th of March, we celebrated International Women's Day, and the empowering women is very important. So empowering women to demonstrate their symptom is also something which is included in the new guidelines, and the new guidelines say that though there is no evidence, but they have suggested that you can actually complement the history taking by asking the patient to keep the note of the symptoms in the diary, or you can give them questionnaire, or you can actually provide them apps. These apps can actually help you to diagnose the endometriosis in a better way. So this is nothing but empowering women to demonstrate their symptoms, something which can be tried, and this is new thing which they have discussed in the new guidelines. Now, once you get a patient with pain in abdomen and you are suspecting endometriosis, the key question is, does diagnostic laparoscopy compared to empirical treatment result in a better symptom management in women suspected of endometriosis? And this key question means there are two options available. Either you can do laparoscopy or you can do empirical treatment. And this key question has got an answer in this new guidelines, which says that two-step approach is a better approach. This is also called as blinded approach. So what is this blinded approach? It says that you first do imaging and diagnose endometriosis. Once you diagnose endometriosis or you're suspecting endometriosis on ultrasound or maybe MRI, give hormonal treatment as a first line treatment. Once you give hormonal treatment, the patient may get relief. Like in case of Neha, she is unmarried. So if she gets relief, be happy. If symptoms improve, I presume that this is endometriosis. And if this is the relief is there, and if the patient is responding to treatment, then you avoid laparoscopy. So the new guidelines say that laparoscopy is no more considered as the method of diagnosis of the endometriosis. They have given more stress on the imaging modality, and if after empirical treatment there is still no response, then you may go for laparoscopy. So as far as possible, avoid laparoscopy is what is called as two-step approach or a blinded approach. So this is new thing which you all should know. Avoid laparoscopy as the first line diagnostic modality in patients with endometriosis. Now comes the drug treatments. The first thing is the analgesics, and the drugs which are available available over the counter like paracetamol, NSAIDs, डोलो 650. डोलो 650 जो है कोविड के बाद ये नेशनल ड्रग घोषित किया गया है. आजकल कोई भी ओवर द काउंटर जाके डोलो 650 की गोली खा लेता है. It has become a national drug. But this is a fact. But then it is okay. The problem with NSAIDs is that the evidence of NSAIDs in the treatment of endometriosis is low, and there is only one RCT which says that NSAID can be tried. The another point which you all should note is that it may inhibit ovulation if you take NSAIDs for a long period and continuously. So there may be a problem with conception. So if the patient is trying for conception, you should avoid NSAIDs for a prolonged duration, and continuous NSAIDs should be avoided. Then second, in the painkillers is the category of neuromodulators. These neuromodulators are mostly used by the pain specialist, and they are not proven superior, and sometimes they may have serious side effects. The drugs which are available are amitriptyline, then selective serotonin uptake inhibitors like duloxetine or gabapentin. These are the drugs which are not considered as superior. So the guidelines are very clear. As far as NSAIDs are concerned, women may be offered NSAIDs or other analgesics to reduce endometriosis associated pain. But this recommendation is a weak recommendation. You may use it, you may use analgesic, but overall the recommendation is a weak recommendation. So that is all about the NSAIDs. The next in the treatment or medical management of endometriosis is the hormonal treatment. And in hormonal treatment, the key question is, are the hormone therapies effective for painful symptoms associated with endometriosis? Uh, because the hormones are steroid dependent. So they act by suppressing the ovarian activity, or they can act directly on steroid receptors and enzyme and may actually help in reducing the lesion and relieving the symptoms. The drugs which are available are progestrogens, antiprogestrogens, combined OC agonist and antagonist, LNG-IOCD, letrozole, and danazole. So all these drugs are discussed at length in the new guidelines, but unfortunately they have said that finding a good therapy is often trial and error basis. You may not get good response. None is free of side effects, and efficacy and safety and side effects are highly individualized. So you may use any treatment, all are good. There is significant reduction of pain, but it is all trial and error. So what is the moderate evidence and a strong recommendation? Strong recommendation says that you can offer hormonal treatment like combined OC pills, progestogens, GnRH agonist or antagonist as one of the options to reduce endometriosis associated pain. But this is the decision which is a shared decision, and you have to individualize the treatment depending on the response. You may get good response with some of the drugs, you may not get good response with other drugs. So it is all trial and error. The first is combined OCPs. They have said that COC or combined OCPs are good. Efficacy is good, but if you take it continuously, it is better than taking it cyclically. So don't take it for 21 days with 7 days gap. Give it continuously. It is actually cost effective. There are the studies which have tried to the compare the vaginal ring with a patch. They have said that vaginal ring is better than patch. Then they have tried to compare desogestrel only pill with COC pills. They have said that desogestrel is better, and also there are so many drugs which are available in market, so you can individualize the treatment. One thing you have to tell to the patient is possibility of breakthrough bleeding. So what is the recommendation for OC pills? There is a strong recommendation for OC pills, and OC pills can be offered for the endometriosis associated pain as a medical management. And it is said that continuous use of OC pills is preferred over the cyclical use. Next is the progesterone. Progesterone drugs are available in the form of various drugs like medroxyprogesterone, depomedroxyprogesterone, cyproterone acetate, norethistron, desogestrel, dynogest, and then there are antiprogesterones like gestrinone. They are found to be effective. They have some problems like headache, hirsutism, or seborrhea, but they are effective. There is one study where they have tried to use Dynogest for a long-term use, and they have done a trial of 52 weeks, and they have found that Long-term use of Dynogest for 5 to 2 weeks is also safe. They have also studied various modes of administration like LNG IOS, subdermal implants, injectables, and orals. All these modes of administration have studied. But one thing they have clearly mentioned in the new guidelines is that oral danazol should not be used. So it is now a history. Danazol is a history. I still remember during our college days, the treatment of choice for endometriosis was danazol. Now danazol is no more a drug recommended. Recommendations are very clear that it should not be used. So the guidelines say that you can use progestrogens for the treatment of endometriosis. It recommends that side effects should be taken into consideration, and LNG IUCDs are said to be good to reduce endometriosis associated pain. Next is agonist. Agonists are the drugs which are given in the form of depot preparation. They are injectables. As far as the efficacy is concerned, they are good, but the safety problem is there. The side effects are always there with GnRH agonist. You have to give add-back therapy in the form of progesterone, OC pills, or selective estrogen receptor modulators, tibolone or testosterone, because there is the possibility of osteoporosis. All the menopausal symptoms are very severe. You should not give this drug in adolescents and young adults because of its impact on the bone mineral density. Something which you all should remember. Do not give leuproid injection for adolescents and young adults. And there is a strong recommendation that these drugs otherwise are effective. So recommendations say that it is an effective treatment. But recommendations also say that these treatments should be taken as a second line treatment after OC pills or progestrogens. And whenever you have this GnRH agonist, you must give add back therapy to the patient so that the menopausal symptoms are not there. So if you just look at algorithm, second in the algorithm is after progesterone and OC pills comes GnRH agonist. So it is second in the line treatment. So it is second line treatment for the pain. Another thing which is coming up now and which has been added in this update is GnRH antagonist. This is new, ये नया है. और GnRH antagonist जो है, we know injectable GnRH antagonists, cetrorelix, but there are oral antagonists which are available like elgolix, and the trials are on regarding the use of oral antagonists for the treatment, and there is an emerging evidence that they are effective orally also. So the guidelines have recommended GnRH antagonist orally as a second line treatment for the pain associated with endometriosis, similar to agonist. So agonist antagonist both can be used as second line treatment, and oral antagonists are available. The third in the line is aromatase inhibitors, that is letrozole. Now letrozole is a good drug, but they have problem like dryness of vagina, hot flushes, impact on bone mineral density. And another thing is these drugs should not be used for ovulation induction. We are using this drug for pain relief. So you have to give it continuously over the period of 3 months. So there are two uses of letrozole. One is ovulation induction, which we all know, and the second is a pain management. And for pain management, you have to get for the period of 3 months. And whenever you give this, the guidelines say that you should give letrozole as a third line treatment only to the and should be preserved for pain which is refractory to other treatment. That means ocipils or progesterone is the first line treatment, agonist and antagonist is the second line treatment, and letrozole comes as a third line treatment. And only refractory pain should be given letrozole. That is what guidelines clearly mention. Now, if you are giving this treatment in the patients where surgery is required, how do we give this treatment? Medical treatment should not be given before surgery. Pre-surgery medical treatment is rejected. It is not recommended to improve the outcome of the surgery. But the post-surgical treatment is recommended provided the patient is not desiring immediate pregnancy. So if you are not expecting pregnancy or if you don't want treatment of pregnancy to start, then you can definitely give post-op GnRH agonist or post-op progestrogens to reduce the pain associated with the surgery. अब एक और सवाल जो मन में आता है कि सर्जन बड़ा है या फिजिशियन बड़ा है. तो this is the key question, that are surgical therapies more effective than medical therapy in women with endometriosis with pain symptoms? और इस बारे में एस्ट्रे ने कुछ कंक्लूजन नहीं दिया है, उन्होंने चुप्पी साधी है। उन्होंने कहा है कि इट कुड नॉट बी कंक्लूडेड whether the surgical treatment is better than medical treatment. So both the treatments have their pros and cons, and they have given the opinion that there is no conclusion as far as whether the surgical or medical treatment is effective. They have also said that non-medical treatment in the form of Chinese treatment, drugs or herbs or electrotherapy, all these things are not recommended. You should not recommend herb or electrotherapy for the pain associated with endometriosis. If you are treating a patient for infertility, whether we should give the hormonal treatment to this patient or not. Now try to understand this point. Pregnancy, as we all know, is the treatment of endometriosis. It is the best treatment for endometriosis. And all the drugs which we are giving for the treatment of endometriosis are actually creating pseudo pregnancy. So why go for pseudo pregnancy when you can get real pregnancy? So it is very clear, it is outrightly rejected. They have rejected medical treatment in the management of infertility. So if the patient is desiring pregnancy, you should not give medical line of treatment in the patient of endometriosis. So it is very clear. In infertility, if you are doing surgery, then you may give medical treatment post surgery, as we have already discussed. If the patient is not desiring immediate pregnancy, you can give this, and also you can give this medical treatment to reduce the pain followed by pregnancy. After giving 3 months of treatment of medical treatment, you can plan pregnancy also. This will relieve the pain part as well. And this is how you can offer medical treatment after surgery. But otherwise, there is no role of medical treatment in the patients of infertility, and patients with infertility should not be given medical treatment. Also, they have said that in patients with infertility, clinicians should not prescribe pentoxifylline, which was the drug which we have already discussed, other anti-inflammatory drugs, and even letrozole for long-term use to improve natural pregnancy rate. So pentoxifylline ruled out, letrozole for 3 months ruled out, and anti-inflammatory drugs ruled out for the patients with infertility. So it is very clear that you should not give all these drugs if you are desiring pregnancy. There are some studies which have said that antibiotics and even probiotics can also be given in endometriosis, because as we have discussed in the definition of endometriosis, it is an inflammatory process, and since it's an inflammatory process, you may actually give antibiotics as well as probiotics. So we are coming to the concluding remarks of the treatment of endometriosis. So, what is the overview of changes which have taken place in the guidelines of endometriosis? 2014 to 2022, there is a definite change in the guidelines. First change is that they have said that laparoscopy is no more the investigation of choice. You can start empirical treatment, and if the patient responds to empirical treatment, there is no need to do laparoscopy. Danazol is outrightly rejected by the new guidelines. GnRH agonist can be given after surgery, and post-op medical treatment is allowed to treat the endometriosis. Uh, so I conclude with this remarks by Louis Brotherson, who has said way back in 1776 that these women with endometriosis are given life sentence and they are trapped by endometriosis. The words of Louis Brotherson, written in 1776, which are so true even today. So, thank you very much for giving me this wonderful opportunity to interact with you regarding the new guidelines as far as the medical management of endometriosis is concerned. Thank you.